Hi, this is Raj Mehta, and welcome to our sixth and final video lecture on evidence-based medicine. In this video, we're going to be concluding our review of clinical expertise. Specifically, we're going to be discussing biostatistics in studies and experiments. Then we're going to wrap up our lecture series. When discussing biostatistics of any experiment and result, we always have to start by looking at how our results are reported in literature. Most results in studies are either reported as a relative risk or an odds ratio, or some form of the two. And it's important to understand the difference between the two, and we'll use some examples. A relative risk is the risk of a disease given an exposure or treatment compared to the risk of a disease compared to not being exposed to something or not being treated. On the other hand, the odds ratio is just the odds of developing a disease if you're given a certain exposure or treatment compared to the odds of developing a disease if you are not exposed to something or if you are not given a treatment. Most randomized controlled trials and cohort studies calculate relative risk because they can show you the risk of something that happens over time. Case control studies, on the other hand, have to give you odds ratios because they can't actually tell you about the incidence of a disease process. Let's use an example to explain this further. Let me draw a 2x2 contingency table. Let's say I'm doing a cohort study on asthma, and I want to see the effects of smoking on the process of developing asthma in children. So this might be secondhand smoke. Maybe their parents are smoking, and I want to see if we're maybe following 200 kids. Let's see how many kids get asthma and how many don't. So I do this study over a period of, let's say, 5 years, and I find out the following. I find out that of the 80 kids that have asthma, 20 of them were exposed to smoking, 20 were not. And of the kids that don't have asthma, 20 were exposed to smoking and 80 were not. Now to calculate the relative risk, I need to calculate the risk of a disease given exposure, so the risk of getting asthma if you're exposed to smoke. So I'm going to add some letters here. So this would be A over A plus B. That would be my risk of getting asthma if I was exposed to smoke. And I would divide that by my risk of getting asthma if I didn't smoke. And that would be C over C plus D. So in this case, this would be 80 over 100 divided by 20 over 100, which is 4. So in this study, in this cohort study, where I monitored to see how many children got asthma, a child was 4 times more likely, or 4 times at higher risk to develop asthma if they were exposed to smoke compared to if they were not exposed to smoke. Now let's look at these exact same numbers, but let's pretend this was a case control study. Instead of this being a cohort study where I monitor 200 kids over a year to see who got asthma or not, let's say I do a study and I go back and I find out 100 cases of asthma and 100 cases where kids don't have asthma. So my case control study, remember, I begin by finding disease. And I go back and I do chart reviews and surveys, and I find out these same numbers, that like 80 kids that had asthma were smoking, 20 kids were in homes without any smoking. Of all my 100 kids with no asthma, 20 kids were in houses that were smoking and 80 were in houses without smoking. Now because it's a case control, I have to figure out my odds ratio. And so I begin by looking at the odds of developing a disease if given exposure. So the odds of developing asthma if they were smoking. Well, the odds of developing asthma if you're smoking is just A to B, or 80 to 20. The odds of developing disease given no exposure, so that would be the odds of developing asthma if there was no exposure, that would just be C to D, or 20 to 80. If I did the math, this would give me an odds ratio of 16. So you can see two things. Number one, odds ratios are calculated differently from relative risk, and two, odds ratios tend to be much higher than relative risk. In most studies, what we really want to know is the relative risk. We want to know the risk of getting a disease, not necessarily the odds of getting it. But qualitatively, when you have an event rate that's very rare, then the odds ratio is almost equivalent to a relative risk. So for many studies, when you're thinking about this, you can kind of think about the odds ratio the way you think about relative risk, but keep in mind that you calculate them very differently, and odds ratios are often going to be a little bit larger and overestimate numbers compared to your relative risk. Let's move on. There are a couple more terms that we have to know in addition to relative risk. There's relative risk reduction, absolute risk reduction, and number needed to treat. I'm going to again use an example scenario to best illustrate what these concepts mean. Let's say I want to try out a new treatment, an antibiotic, and I want to see if it helps treat an infection. So I do a study where I give an antibiotic to one group and a placebo to another, and I see who gets infection and who gets no infection. And then I look at my results. So these are the results I get. Okay, 14 people got antibiotics, still had the infection. 119 people got the antibiotics and infection cleared. 120 people got the placebo and after treatment period still had the infection, and 20 people who got the placebo after our treatment period were cured and didn't have the infection. So I want to calculate my relative risk, and again that would be 14 divided by a total number of people on antibiotics divided by placebo with infection divided by the total number of people on placebo. If I calculate that, I get 0.12. What this is saying is my risk of getting an infection, of having an infection on the antibiotic, is 0.12 compared to my risk of having an infection if I was on the placebo. That's kind of cumbersome to say. So sometimes what we'll use is the relative risk reduction to describe this number. The relative risk reduction is a percentage and is calculated by 1 minus the relative risk. In this case it would be 88%. My relative risk reduction tells me that I'm 88% less likely to have the antibiotic if I get treated. So again, my relative risk reduction just comes from my relative risk. It's another way of describing quantitatively what this is. My absolute risk reduction is similar but a little bit different from my relative risk. In my absolute risk reduction, I'm trying to find out the total number of events on my exposure group, and in this case that would be the number of people on antibiotics who have an infection, and I subtract that from the events of my infection from people on placebo. So again, my absolute risk reduction will be the risk of events of infections on a placebo minus the risk of events of infection on antibiotics. How does this differ from relative risk? Well, relative risk is dividing the two. It's dividing the events of infection on placebo. So my relative risk, I'm dividing the risk of my event on treatment or on antibiotics into my risk of event on my placebo. My absolute risk, I'm subtracting the two. So I'm trying to find out the absolute difference rather than the relative difference of these two events. And that's a very key and important point. In both these, you're calculating the risk of events, but you're getting a different answer. So if I do the math here, I get 0.77. So that's my absolute risk reduction. What does that mean? That means I'm going to have 0.77 less events if I take the antibiotic or treatment. That's kind of cumbersome to say. So instead of using the absolute risk reduction to phrase things, we use number needed to treat. Number needed to treat is just 1 over the absolute risk reduction. In this case, it's 1 over 0.77, which is 1.3. Our number needed to treat just tells us how many people we have to treat before someone gets a benefit. So I have to treat 1.3 patients before one patient will benefit in being treated by an antibiotic. And that's pretty good. 1 is as good as it gets. It means pretty much everyone you treat is going to get better. The value of all this is ultimately you figure out your number needed to treat, because this is what clinically is significant and can help you make decisions. Your relative risk reduction, absolute risk reduction, you want to use them all to help you figure out your number needed to treat. Now in a lot of studies, the relative risk reduction can be misleading. You can look at this number and think an effect is really great, but the number needed to treat may not be as impressive as you think. And that's why it's always important to consider and calculate your absolute risk reduction and figure out your number needed to treat. I'm going to go through another example to illustrate this point. Let's look at a test for a drug, let's say a statin, to see if it prevents a heart attack. So we have two groups. Let's say in one group we give a statin and in the other group we give a placebo. And we do a study, and this is what we find out after 1 year. we find out that in our statin group, we had 100 patients that have heart attack, 5,000 with no heart attack. In our placebo group, we had 153 patients with a heart attack and 5,000 without a heart attack. So let's calculate our relative risk. So I find out my relative risk is 0.64. That would give me a relative risk reduction of 36%. So that sounds pretty good. If you're on a statin, you're 36% less likely to get a heart attack. Now let's calculate our absolute risk reduction. So this would be events on placebo minus the events on treatment, and I get my absolute risk reduction is 0.01. Okay, so what is my number needed to treat? 1 divided by 0.01, or 100. Okay, so unlike my antibiotic where I had an 84% risk reduction and number needed to treat of 1.3, here my number needed to treat is 100. I have to treat 100 patients before that statin helped prevent one heart attack. So if you just look at the relative risk reduction, you can miss the effect of your treatment, and this is really, really important. It's more important to understand your number needed to treat for clinical significance. This relative risk reduction can be very confusing. If I was in a store and I told you you had 50% off whatever you bought next, you'd be like, wow, that's great. But if I bought a $2 candy bar, all I'd save is $1. That's not that impressive. If I bought, on the other hand, a $5,000 gold necklace, I could save $2,500. That's much more impressive. So just knowing this relative risk is not really that helpful. You need to know your absolute risk reduction and number needed to treat. There's one more concept I want to go over before we finish this video series. I want to discuss briefly the concept of p-values and confidence interval and how it applies here. So in this study, we said that statins are helpful and they're 36% likely to reduce your risk of getting a heart attack, and your relative risk is 0.64. How do we know this is statistically significant? Well, the way we try and figure out statistically significant is by calculating a p-value. The p-value is the probability of getting a result, or the result we have, if our null hypothesis is true. Our null hypothesis in this study would be that statins and placebo have no effect. So if statins and placebo had no effect, what would be the probability of getting this result? Let's say our probability is 0.02. That means the probability of getting this result, if there's no difference, would be 2 in 100. That's really small. In fact, depending on our threshold cutoff for alpha, which we discussed in video 2, if our p-value is less than our agreed upon alpha, we reject the null hypothesis and conclude that the alternative hypothesis is true. So in this case, we would conclude that statins are better than placebo. So how do we know this result wasn't due to chance? How do we remove chance from adding error to our study? We remove chance by calculating this p-value and making sure it's below our threshold of alpha. And that way we can be confident that this result isn't due to chance. How confident are we that it's not due to chance? I'm 95% confident that it's not due to chance. Why 95? Because I set my alpha to 0.05 or 5%. If I set my alpha to 0.05, that means that there's a 95% confidence that my result I'm getting is true. Now whenever you see a p-value, you'll also see a confidence interval. What is this? Well, anytime you do any statistics, there's always some uncertainty. So in this case, even though my relative risk is 0.64, there's going to be an uncertainty between what the true value might be. That uncertainty might be something from 0.50 to say 0.86. So that my relative risk is 0.64, but it could be from 0.5 to 0.86 once I consider my uncertainty. This range is known as your confidence interval. Our confidence interval is the estimated range for the true value of the relative risk. And most confidence intervals are a 95% confidence interval. You'll see that reported using an alpha of 0.05. The more precise our study, the more narrow our confidence interval. The less precise our study, the wider the confidence interval. Again, when you have a good confidence interval and an appropriate p-value, you can be confident that your study has found statistical significance. Now we can get to the final step of our EBM process. Once we've used our biostatistics to analyze our result, we can begin deciding if this is clinically appropriate for our patient and helpful for them. If we go back to our circles of use, we're trying to use our research evidence in a certain specific clinical setting, take into account our patient values to find the best way to express our clinical expertise. The first step in this is making sure that our research evidence is statistically significant. If it's not statistically significant, it's probably not going to be very applicable. 2, we want to evaluate the validity of our results. If we're looking at a study that has a lot of bias and we're not sure about the validity, we can't be very confident of applying it to our patient's care. 3, always look at the number needed to treat or number needed to harm. The number needed to treat or number needed to harm will always reduce the information for you in a way that's clinically helpful. Finally, look at important outcomes. What is the outcomes of the research evidence you're looking at? Does it apply to your patient? What are the outcomes your patient's looking at? Once you've reviewed all these things from your research evidence, you can determine if it has any clinical significance. Just because a study is statistically significant doesn't mean it's clinically significant. Clinical significance requires more judgment and thought. Ultimately, it's about practicing EBM well. The last and final process in EBM is evaluating the results. Once we've applied our evidence-based medicine in practice, we want to see what happens and start over again. EBM is a continuing lifelong process and critical toward being a good clinician. This ends our video lecture series on evidence-based medicine. Thank you so much for listening.